we really appreciate you taking time to join us for this call. This is the second webinar on PEPFAR. Today we are going to focus on data, PEPFAR data interpretation. So we are going to be covering how PEPFAR presents data in public settings, such as meetings on the country operational plan, during the review meetings that have taken place in Joburg before, how to interpret common PEPFAR graphs and charts. I know we've all been to where PEPFAR is using a number of graphs, and we can hardly keep up on the amount of information that is being shared with us and just how it's presented. We are also going to be speaking about methods that have been used to question or intervene when civil society has used the PEPFAR data itself to advocate for various things, such as increase in targets and increase the number of people who get testing, or if it's about focusing on various areas if we needed PEPFAR to do that. So I'm going to start and go through, speak a bit about the tactics that have been used by civil society to slow down the process, and how some of the understanding of civil society of data has led to wins during the COP process. So just to give a background, there's how the process works is that there's various meetings that are held in the country, and then they usually culminate to PEPFAR COP review that has been previously, in the last two reviews have been held in Joburg, where it's a 3-day per country discussion where country teams present their data. They present the targets that they would wish to cover for the year for treatment, testing, retention. If it's buying of machines for viral load testing, they would present that data. They would present also data about how they've been engaging with civil society, how they've been engaging with governments, and mainly their plans for the year. So civil society has used this space to be able to, has been represented. There's always space, maybe about 1-2 people to go to the review per country. Various countries have been represented with various people. I know for countries like Uganda, for the 12 COP 2017, there was a representative of people with HIV, and there was a representative of key populations present. Through these meetings, as civil society has been present, PEPFAR would present its slides, and we have in countries like Kenya, civil society has taken a keen interest in asking PEPFAR to slow down and repeat various slides that they've already presented, and they have used the space to be able to ask questions about information that didn't really appear on slides. So there's been wins such as in the 2017 review, key populations, 2016, sorry, I apologize, where key populations were present, and when key population data for MSM was presented, the representative of key population present was able to see that the target that PEPFAR wanted to reach for the year was less than the targets that his organization was able to reach. And communities, we were able to support him to stop the process and say, you know what, we need to review this. We need to review this data to be able to ensure that PEPFAR is able to have meaningful impact in reaching key populations. Another example has been in the process this year for 2017 in Uganda, where when data was presented for PrEP targets, the number that was supposed to be reached was 5,000 MSM with PrEP services for the entire year, and the representative and civil society people who are present were able to say, no, we think that we can be able to reach more people given a chance. And they were able to win an increase of 5,000 to about 11,000 MSM getting services. The process of reviewing data and going through data and understanding data requires quite a bit of support from country team chairs. So at the review, there's always, each country is assigned a country chair, and the country chair is the person who leads the discussion and tells them to move the slides along and tells them to stop and explain what this means. And per slide, they would normally be the ones who would be coordinating the process of review. And they have been a key ally in some countries in being able to include civil society voices in interpreting data for the PEPFAR process. I don't want to spend quite a bit of time just speaking about the wins. I want to introduce Brian Honermann from amfAR, who has been a great asset. I'm echoing. I don't know whether anybody can hear me. Hello?
Can people who are not speaking at the moment just keep their phones muted?
Yes, so I would like to introduce Brian Honermann from amfAR, who's going to today take us through how to read the various slides and the various graphs that you get to see quite a bit in country. And we will get a chance to, at the end of his presentation, ask questions about how to best interpret the data that we've been presented with in our own countries. The questions we have on what it means when you see two different graphs on testing, when you see what it means when you have a target that says when you have different targets and interpreting what those targets are. So Brian, please take over.
Thank you, Maureen, and thank you to everybody for joining. So I think Maureen's already covered it. I mean, the basic objective here, if we go to the next slide, we're just going to go over some examples of how PEPFAR in the COP reviews actually present slides and data around HIV testing, around linkage rates, around treatment coverage, and some on key populations, and we'll also touch on budgets if we have the chance. Next slide. And so this is just saying that it is important to note that every country presents data very, very differently. That's both a feature and a bug of the process, in that the countries evaluate their data different from each other, but it makes it really challenging to say precisely how data are going to be presented. But this gives you an idea of what types of presentations are likely to come up. Next slide. And next slide. So this is just the first set, talking about HIV testing. We put some resources there on the right-hand side. All of the slides that we're going to show that are related to the PEPFAR presentation of data come from these approval meeting outbriefs and the link that is there. So you can go and you can download the full slide deck that PEPFAR used at the final COP review. These are from the COP17 process. For those who want to dive into the details, all of the indicators and everything that we're going to talk about are defined in this PEPFAR Monitoring, Evaluation, and Reporting Guide. It's a very thorough document and very technical, but I do think it helps demystify some of the terminology that PEPFAR uses. And then if you want to access the data on a quarterly basis, this is more sort of the raw data and a website that presents the data that PEPFAR has put up. That's the PEPFAR quarterly data that you see there. PEPFAR teams will sometimes call that the panorama data. Next slide. So just a few terms for the HIV testing side. A lot of times you'll see this term HTC-TST, sometimes referred to as HTS or HTC. All it means is it's the PEPFAR indicator for the number of HIV tests conducted. Importantly, it's not the number of people tested, it's the number of tests that were conducted. The HTC-TST pause, sometimes HTS pause or HTC pause, just means the number of positive tests that were conducted. So presumptively the number of people who were identified as positive. The testing yield, this isn't something that PEPFAR talks about a lot, is the percentage of HIV tests that were positive. These range depending on what you're looking at and what country you're in. But PEPFAR has made a big deal about trying to increase the proportion of HIV tests that are coming back positive, so that we're not retesting the same people who are negative over and over again. And then the testing modality means how people were identified to be tested. Generally, there's facility-based testing, there's community testing, there's PITC, which is provider-initiated testing and counseling, index testing, which is testing the partners of somebody who has just recently tested positive, VCT, outreach clinics, and then targeted outreach, which is generally a form of community testing, but there's no formal definition of what that really means, and so that's always a question that should be asked. Next slide. So this is the first example we're going to look at, and this is an example from Nigeria. And this is PEPFAR presenting the number of tests that were done as well as the number of positives that were identified in two different modalities, and over time. So this extends for all of fiscal year 16 and the first 2 quarters of fiscal year 17, which were the only data that were available when the COP reviews were last year. So that that yellow line at the top is the total number of facility-based tests that were conducted, and the gray line in the middle is the total number of community-based tests that were conducted. And those are mapped to the scale that's on the left-hand side, the axis that's on the left-hand side, for the number of tests that were done. The green bar shows the number of HIV positive test results in facilities, and the gray bars show the number of HIV positive test results in community testing programs. These are both charted against the axis on the right hand side of the screen. So to find the yields here, which is again something that PEPFAR would be very interested in, you would generally take the number for the bar and divide it by the corresponding line. So, for instance, in FY16 quarter 1, facility-based testing had a yield of 56,142 divided by 1,587,602, or about 3.5%. At the same time, community-based testing had a yield of 5,885 divided by 894,574, or 0.65%. Basically meaning that community testing was much less efficient at finding positive individuals. When you get into FY17 quarter 2, the last set of data on the right, you can see the number of tests that were being conducted changed a lot. But overall, the number of positives didn't change quite as much. Here, the facility-based testing had actually dropped a little bit to 2.9%. That's 46,873 divided by 1.6 million. And community testing had a yield of 1.77%, which went up a lot because they identified more positives on fewer tests. So they'd obviously done something. And so this is where you would potentially want to ask questions about what did they change in the program to really be able to identify how they're doing testing or where they stopped testing in particular, to see if services have been decreased or whether this is a different change in the program. And to be clear, I find this to be a very confusing way to present the data, but it is a very common way that PEPFAR presents these data. Next slide. So this is an example of similar data from Zimbabwe. And this is breaking the results down by the different types of testing modalities. So here, the bars, both the blue and the orange part of the bar, represent the total number of tests that were conducted. And the orange part represents the number of HIV positive tests that were found. And then the red diamonds there represent the yield rate for each of these different testing modalities in the different quarters that are presented. These are, I believe, fiscal year 17, quarter 1, and quarter 2 data. There's something to notice here that I think is really important, that the total number of positive people identified are mostly in the provider-initiated counseling and testing, or testing and counseling TA category. That means that the thickness of those orange parts shows that. So even though index testing, that group in the middle, has a much higher yield, it doesn't actually contribute that much to the total number of people being newly identified. So you could ask a question about, can we expand index testing to identify a lot more people with this higher yield modality that we have in index testing? But you could also ask, what is the TA that we're providing? What is and where are the better opportunities for investment of our resources? The other question that I would always ask here is, what is this targeted outreach? What does that program really look like? Where is it happening? What populations is it really identifying? Is it going after youth? Is it going after men? Is it going after key populations? Anything like that. I think those are good questions to ask about slides like these. Next slide. This is another example from Uganda. It works very similarly, but the things it is charting are different. Here, the blue bars represent the number of HIV tests that have been conducted, and they're matched to the axis on the left. And then the red line is the already calculated yield for each quarter, so right around 3% on average, and scaled according to the axis on the right-hand side. There's something about this chart that I think is important for people to see. In the first place, the axis on the right, you see at the bottom, it starts at 2.1%, and it goes up to 3.3%. In almost every circumstance, y-axes like this should always start at 0. And the only times that they generally don't start at 0, they should be declaring why they start at 0, or why they don't start at 0. And the reason for that is to prevent relatively small differences from being made to look like they're much more significant differences than they are. So you can see in the red line that's being charted according to the scale on the right that there's this sort of range between a yield of 2.8% and 3.2%. That's actually not a very big range, but it's being made on this graph to look quite substantial. And so importantly, you look at these last two quarters, fiscal year 17 quarter 1 and fiscal year 17 quarter 2, and the yield looks like it goes from 2.8% to 3.1% in sort of this dramatic line up, like they're doing a much better job. But what's important to recognize there is that that increase in the yield matched against the reduction in the number of tests that were conducted. So they went from 2,125,000 tests down to 1.5 million tests being conducted. Actually resulted in fewer individuals being identified. So in quarter 1, the 2.8% of 2.1 million tests would be about 59,500 HIV positive individuals being identified in the quarter. And then in the second quarter, the 3.1% of 1.5 million tests would be about 48,000. So about 11,000 fewer people were being identified here, even though it looks from a yield perspective like they're doing better. So I would ask in this case, like, why did they actually start the scale on the right or why didn't they start the scale on the right at 0? And then really ask questions about how meaningful these differences are between a 2.8% and a 3.1, and that this range doesn't actually look like it moves all that much. And then, are we actually improving the program by testing fewer people? Again, based on the numbers that they're presenting here, they actually ended up identifying fewer HIV positive individuals than they did in the previous quarter. Next slide. So this is just another example from Zambia. I'm going to go through it very quickly. It works in essentially exactly the same way. That the bars represent the total number of tests that were conducted, and the red circles represent the yield that each of those bars had. So the proportion of HIV positive tests that there were. The important thing to note here is that they were able in Zambia here to disaggregate men and women. So the men or the women are represented in the pink bars, and the men are represented in the blue bars. For each of these different testing modalities, so community-based testing and counseling, index-based testing, provider-initiated testing and counseling, and then PMTCT A&C clinics, and VCT standalone and facility clinics. And they were able to disaggregate by age group. And the important thing about this is these are the level of data that are available and that you can be asking for from your country team, particularly if you get slides in advance and you're concerned about whether we're succeeding on testing young people or not. You can ask for slides to be presented that specifically break down the data in these ways, that look at these different age groups. The other thing that I would want to ask in this case is, if you look, their VCT yield rates are quite high, around 12% in the VCT 25 and above. And what's interesting is that their index-based testing is much lower for yield rates. And that's, frankly, in this case, an anomaly. Usually, as we saw in the previous slide, index-based testing is a much higher yield. And so this is a period where I'd want to ask, what's going on with our index-based testing that our program is finding fewer positives than what our standard VCT clinics are finding. I think it's a very interesting anomaly in the data here. Next slide.
Brian, just before you continue.
Yep.
Can you hear me? Yes. So I really just wanted to highlight the fact that looking at this slide.
Kevin, can you go back?
No, he doesn't need to go back. The fact that a lot of testing has, in your country, if you see a lot of testing happening and that there's 10 million people, it doesn't necessarily mean that your country is doing well in terms of getting the amount of people you need to get as positive so that you offer treatment to them. So sometimes when data is presented to us and we see a lot of testing took place, we tend to miss the fact that some parts where, let's say, that the number of positives were actually not what PEPFAR intended to get. So it may be that they intended to get 200,000 positives. They've done 10 million tests but only gotten 50,000. That's bad. We need them. This gives us an opportunity for us to be able to challenge the methods that they've been using to test. Is it that they've been testing people at the facilities? Do they need to test more people at the clinic? Do they need to test more men? It gives us a chance to be able to have that conversation. Also, in the slides that have been presented by Brian, you get to see that PEPFAR tends to present information about where people are getting tested. It's also a really great opportunity for civil society to be able to come and say, hey, my organization has been testing people in this place, and we've gotten a lot more people who are positive through this method. Please take it up, as it will mean that your programs are able to get more people who are positive to put on treatment. So looking at things like those ones as advocacy points and things to recommend when you're writing your recommendations for PEPFAR are also really key. Yes. Thanks.
Thanks, Maureen. So I'm just going to go on to the next set of slides that look at linkage rates. Again, Kevin, I think you missed a slide. There we go. Go next slide. So just again, terms. Linkage in PEPFAR's language means the number of newly identified HIV positive individuals, so those HTS, TST POS that we talked about a minute ago, or the yields, that were initiated onto treatment in either the quarter or the year or whatever the time period is that they're looking at. TX new is PEPFAR's indicator, meaning the number of people who were newly initiated on ARV treatment. It only counts first-time people being enrolled onto treatment. It doesn't count people who were initiated on treatment and then fell off treatment and then reinitiated on treatment. TX cur is a PEPFAR indicator, meaning the total number of people who are currently on ARV treatment that get some PEPFAR support. And then a proxy is an indicator that represents something else. So in this case, PEPFAR in almost no circumstance tracks individual patients. So it uses two indicators, those HTS, TST POS, as well as the TX new, to simulate what the linkage rate is. To basically say, well, we identified 10,000 people positive in this quarter, and we added 7,000 people onto treatment this quarter, so we assume that most of those 7,000 are the same as those 10,000. But it doesn't necessarily mean that, the same people. So it's just important to be somewhat cognizant of that, because it's important to understand when you get to slides like this. So this is a slide from South Africa. And the blue bars now represent the total number of people who were tested positive in each district or district municipality, as is the case here. And the orange bars represent the number of people who are newly initiated onto treatment. And then the black diamonds, which are scaled according to the axis on the right, is the linkage rate in each of these municipalities. That green line across the graph, it represents what 90-90-90 would dictate is necessary, so 90%. So ideally, we would see all of those black diamonds being above the green line, either at or above the green line. Overall, obviously, the basic structure of this graph is the same as what we've already been talking about. That is an advantage that a lot of these really do come in like this. But if you notice some of those numbers in the middle, specifically like Amatole has a linkage rate of 124%. This can happen for a couple of reasons. Because it's a proxy indicator, first of all, it's not tracking the same individuals. So they may have gone out and found patients who had previously been diagnosed but never started on ARVs and got them initiated under treatment. So you see these sort of bumps when like test and treat went into effect. Those sorts of patients were used to be called the pre-ART or care patients. Second, people may have been diagnosed in a different district but decided to start treatment somewhere else. This can happen where there's a big community testing program, but where a hospital or a clinic is on a border between a couple of different districts, and people tend to go towards that bigger hospital. These are always questions that I think it's important to ask. And, you know, in this particular case, I don't really understand how they've sorted this graph. There seems to be this general idea of the number of HIV tests that were conducted is how they scaled it from left to right, but it's not really true. So I'm not clear as to what the organizational decision here was in this graph. So sometimes there just isn't a right answer, I think. Next slide. This is another example from Malawi. Here the PEPFAR team is looking at how well they are doing on linkage for different age groups and sexes, so particularly for pediatric patients. This time the bars represent the linkage percentage for each sex and age group. Blue are males, green are females, and yellow is the overall average of both males and females. One other thing, though, there's a footnote that points out that these data are only for 41 sites in Blantyre, Chiolo, Tsirazulu, and Nano districts. They're not necessarily representative of the country as a whole. In this case, the data were just being presented as part of describing the pilot program that the country was running of index testing in 41 sites. So these linkage rates are those tested as part of that campaign. And it's just important to understand sometimes when the data are being presented that you're really clear about what it is that they're talking about. So in this case, this isn't representative of what the testing program is as a whole. It's just representative of what this little program is. It's also really important to be careful about ascribing something to the differences in the sexes here or even across the ages. This is especially true in the case of the sex differences in the results in these data. The pattern isn't entirely consistent between the sexes. In 1 to 9-year-olds, girls had better linkage rates than males, but then in 10 to 20-plus-year-olds, males had better linkage rates than females. You know, a lot of these may or may not actually be indicative of anything, particularly if you don't know how big each population was. So these could be really small numbers that they're showing data for. Next slide. This one just shows what that program was, and what you see is that overall there were only 1,978 patients that were made up all of those charts. So that's just important for context. Next slide. This is an example from Zambia. Here, again, the chart works basically the same way. The blue chart, or the blue bars, are scaled according to the axis on the left, and they represent the number of positive people identified Now this one is by site. So this is at the company clinic, at the Spring of Life clinic, at the hospital, etc. So they can go down to data about every single individual site from which PEPFAR gathers data. The orange bars represent the number of people newly initiated on treatment. And then you can see these are all just from Kitwe district in Zambia. And you can see the green circles represent, or the gray circles represent the linkage rate at each of these facilities. PEPFAR, in particular, Ambassador Burks, really likes these sorts of graphs because they show that even within a district, this district may look like it's performing well overall, or it may look like it's performing badly overall. But importantly, unless you go down to sort of these sites, and you can ask about this always, are there sites that are doing well in that district, and why are there sites that are doing really poorly? I think that's important to follow up on and ask about always. Maureen, do you have anything?
Yes. So one of the things that we've won before is looking at slides where linkage has really been bad. For key populations in Kenya, we were able to show that linkage after testing to main facility was really terrible for key populations. And through that, we were able to win support for community organizations to move from just testing facilities to having comprehensive care. But that's that, yeah.
Okay, so next slide. So this is going to look at treatment coverage again. This is also part of the second 90. Next slide. So again, TX new is the number of new people initiated on treatment. TX cur is the total number of people currently on treatment. Then there's this net new indicator, which is a PEPFAR assessment of how many people were actually added onto treatment minus how many people fell off of treatment, either because they were lost to follow-up, because they died, because they transferred out. There are all sorts of reasons that people may not be accessing treatment anymore. So PEPFAR uses this indicator called the TX net new, or sometimes just net new indicator, and that's the important one that tracks how much progress is actually being made. Retention is the proportion of patients who were retained on treatment. And then this is just an important concept about indicators of whether they're cumulative or whether they're rolling. So a cumulative indicator, TX cur, or the total number of people currently on treatment, is a cumulative indicator in that it includes all the results from the previous years and quarters of the program. So it is a reflection of right now what's happening in the current quarter or the current year, but it's also been increased because of the performance from the previous years. So it's not reflective of only what happened in the last year. Next slide. So this is an example that shows, I think quite well from Nigeria, that difference between a rolling indicator and a cumulative indicator. So here, the TX new are being presented on the left-hand side. Those are the number of new people initiated onto treatment. The targets are in blue bars, and the results through 2 quarters are in the orange bars. This is through 2 quarters, so they should be about 50% of the way through the targets at this point, in general, on a rolling indicator. So you can see on the left-hand side, for the TX new, they're doing fairly well. They're at about 46% of their target. That's what the green triangle there in between the 2 bars represents. And that's important. So they're doing pretty well on that particular indicator. On the right is the current on-treatment target. So they're going for having 832,599 people on treatment. But crucially, the current on-treatment target is a cumulative target and from all the years that PEPFAR has been working in the country. And because it's cumulative, the percentage of performance doesn't really mean anything. So you see there's that green triangle there that's at about 87%. That's 720,000 divided by 832,000. It's right around 87%. So it looks like they're about 87% of the way through their target through 2 quarters. And that would appear to be a good thing. But that's because it started much of the way through. At the beginning of the year, most of those people were already on treatment. If you look at the data from the Panorama website, at the beginning of the year, they actually had 700,262 already on treatment, so they already had 84% of their target achieved just coming into the year. So only moving up to 720,000 or 87% didn't really improve that much. This is where the net new indicator becomes really important. If they started the year at 700,000 people on treatment and their goal was to get to 832,000 people on treatment, that means their net new target was around 132,337. Right now, after 2 quarters, they've only added 20,000 people onto the rolls, or about 15% of the target. And that's a really big problem. It's a really important thing to pick up in how they're presenting the data here. But the graph isn't really showing that lack of progress. It instead only shows what appears to be relatively good progress, both in the treatment new side, where they're about halfway through their targets, but also on the treatment current side, it looks like they're doing well because they're 87% of the way through their target, but they haven't been increasing at the rate that they should be. And that's a big concern, and that's one of the most important questions to be asking about when thinking about the 90-90-90 indicators. Next slide. This is an example from Malawi, and I think this is actually a good explanation for a slide, or an attempt to explain the progress and difficulties in making progress towards the target. So again, the blue bars are the quarterly results towards the target, and the red bar represents the target. So they're trying to get to 914,000 people on treatment by the end of the year. And they're showing that between quarter 4 of last year and quarter 1 of 2017, they only went up by about 17,000 patients on treatment. They only had a net new of 17,000. But part of what they're saying is, either as part of the pivot or some of these reductions in services that I'm sure people have been aware of, they stopped counting at 150 sites. So there were 11,600 people that they used to count as being on treatment that were part of that 696,000 in 2016 at quarter 4 that weren't counted anymore in quarter 1 because they stopped supporting those sites. So an increase of 17,000 should really be taken into context of, but they also lost 11,000, not because the 11,000 people dropped off of treatment, but because they stopped counting those people as PEPFAR-supported people. But then when you look at between quarter 1 and quarter 2, their net new went up by 75,000. And what they say is, we jumped a lot because we did the pre-art register mop-up. So this is basically, they initiated test and treat during this time period. And they went out and found all those pre-art patients that they couldn't identify before and put them on treatment. And then they added 145 more sites. And so they didn't really do anything in those 145 sites per se. They just started counting the people who were on treatment at those sites as part of their results. And I think that's really important because that added 35,500 people to their number. So if they're looking at the progress being made, it's not really that much of their own progress that's being made. They only added about 40,000 new people on treatment. That's some progress, but they shouldn't continue to expect to see 75,000 new people on treatment every quarter going forward. And I think they make that clear. Next slide. This is an example from Zambia, and I think it's actually an example of where people make the case poorly about what they expect to see in the future. And I'm going to just slide through this real quick. You can see this is a trend of the new people being initiated on treatment every quarter going back to 2013. And you can see the line is basically static. It stays about the same every quarter until 2016 in quarter 4 when Test and Treat was rolled out. And you see that big spike that happens because they went out and found all of those new people on treatment, all those people who were registered but not on treatment, and they put them on treatment. So you've got this big spike up, and then it dropped again because they had gone through most of those rolls. And then you see this sort of increase between quarter 1 and quarter 2 a little bit in fiscal year 17. And then they just decided to draw a straight line that said, we're going to continue this exact same progress for the rest of the year, and that will take us almost to our goal, even though we're really underperforming our goal thus far. And I think the point here is just you should always be very, very wary whenever people draw a trend from just 2 data points, especially when there are a lot more data points to draw from. Unless they're arguing that they've fundamentally changed something about the design of the program. So that is something that I would definitely want to ask is, why would they really expect to continue to improve so much? What did they change about the program that they really think that they're going to just dramatically increase the number of people who are being initiated on treatment every quarter going forward? Next slide. Just in the interest of time, I'm going to skip past this one. PEPFAR does really like presenting data and maps, but I think it's really hard to read. But we're happy to distribute these and answer questions later. Next slide. The only thing I want to talk about here is this is showing the new on treatment and the current on treatment from COP16 and from COP17. And the thing I want to talk about is just, if you look at, say, Kinshasa, the second row there, they changed the priority levels for the country. So they went from a sustained district in COP16 to an aggressive district in COP17. And that corresponded in an increase in the targets. And we should be pushing for this massively every time. That in this prioritization process that PEPFAR now goes through, that they should be aggressively trying to add more districts to be saturation in aggressive districts. Maureen?
Yes. We have, so it's about 10 minutes before the end of the call, and we are probably not going to get through all the slides, but we'll make sure that we share the slides with everybody. But we wanted to give a chance to at least get a few questions from the people on the call on any data support or questions that they might have. Sorry, Brian.
No, I think that's right.
Kevin, is there a way to get some of the
yeah, so Maureen, can you hear me? There haven't been questions on the chat box yet, but maybe people can just voice their questions, and you could take a few of them and then field them.
Okay. So wait, people, is there a way we can unmute some people who just want to ask questions on the timing?
Yes.
The conference has been unmuted.
So anybody who has questions? So maybe I can start it off. There was a question on the RSVP list from someone who asked, explain how dating works and how to use it, how to access dating and other database of PEPFAR, and how to understand PMTCT indicators.
Okay, so just going to the data, how to access the data question. If you look at those, like the treatment coverage slide, which is 17, there's that quarterly data report that is there. And we'll do another training or another webinar on how to access the databases that exist in sort of the next webinar and how to utilize those. The PMTCT indicators are something I wanted to cover, and there are a number of them. And so the way PEPFAR handles PMTCT is they look at PMTCT testing, PMTCT positive tests, and then the number of women who are put on treatment as part of the PMTCT program, and then the number of children who were tested within 12 months of being born. And I think those are basically the indicators that they cover. And if we can write up more on that, we've got slides on that, and send those around as well.
If anybody has questions or additions about their process with their experience with PEPFAR data, please feel free to share before we close out.
Maureen, I just sent you a question on WhatsApp.
Oh.
So the question we got on WhatsApp says, please describe all the mechanisms that PEPFAR may use to get KP and community input. For example, does PEPFAR use anything like a CCM that the Global Fund uses? Maureen, I don't know if you want to take this first.
Sorry, I didn't hear that question. I apologize.
I'll describe the mechanisms that PEPFAR uses to get key populations and community input. For example, does it use anything like a CCM?
So the PEPFAR process in country should be open. There is quarterly reports that they give every year. So every quarterly there will be a meeting with PEPFAR where all of civil society should be able to attend. It should just be an email and a listserv, and they give you a place to meet, and everybody has a chance to ask questions. Key population data tends to be reported twice a year, quarter 2 and in the quarter 4. So sometimes you would go to the meeting and you find the data not presented, but it's mostly because it's collected twice a year. There's also opportunities to just ask your PEPFAR coordinator to meet with you. They've been known to meet with various people in various countries that civil society has asked for those meetings. And at the PEPFAR review, there is a mandatory requirement to have a key population representative at the review to speak for key populations. So there's definitely opportunities to engage with PEPFAR.
Yeah, and the only thing I would say in addition to that is that PEPFAR does not use a means like a CCM. There's no specifically formal democratic sort of created body to engage with PEPFAR. It's a much more ad hoc process.
There's a question also on the RSVP list that says, it seems like TB prevention is only available for Q2 and not Q3. This is a mystery. Any thoughts on this?
Yeah, so one of the things about the way PEPFAR collects and distributes data, and this is talked about in that PEPFAR monitoring, evaluation, and reporting guide, is not every indicator is collected for every single quarter. Most of them are reported, or most of the big ones like HIV testing, new on treatment, total number of people on treatment, all of those are reported every single quarter. And then there are ones that are semi-annual or only reported twice per year. So some of the key populations ones that Maureen indicated and the TB indicators are only counted every other quarter, so quarters 2 and quarters 4. And then there are some indicators that are only reported annually, so once per year during quarter 4. And that includes things like the number of infants born to HIV-positive mothers who had a HIV test within 12 months. Some of those only get reported every quarter or every year because it takes a while to collect the data. And there's a table in that graph, and we can add it to the slide deck when we send it out again, that shows when those what indicators are reported in which quarters.
Any questions from senior addition? People on the call?
Yes. Hi, my name is Alice. I work with AIDS Healthcare Foundation in Uganda, and I have 2 questions.
Go ahead.
Go on.
Okay, so first is to thank Maureen and Brian for the presentation. Although I must admit that, yeah, the figures are quite many to be consumed all at a go in one webinar, and I'm glad that you are organizing for another webinar in future. However, at the same point, I want to ask a question with regard to how best can someone, analyze this data within a snapshot. Say, for example, you're attending a meeting, the PEPFAR coordinator is present, and they come up with maybe 2, 3, 4 slides that they are presenting. How best, or what are the key issues that I need to look out for in these presentations that are usually, they're kind of sudden presentations that we are never prepared for at times, but then we want to be able to contribute meaningfully, both to the presentation but also to the information that has been provided. Thank you.
Thanks for that. Maureen, do you want to go first?
No, you start, sorry.
Okay, so I think it's a really good question, and it is, I will say, as somebody who works on these data all the time, I think it is really incredibly difficult to respond to these graphs in real time. I certainly am not capable of doing it. And one of the things that we have started to demand from civil society perspective is that all of the slides and all of the data that are going to be presented be distributed before the meeting. And they should be distributed before, at least, in my mind, at least a week before the meeting, so that people can go through the slides slowly and start to understand and pick apart what the data are showing and what they're not showing. And I think we should demand more and more that those are distributed with notes about what the data are being presented.
Okay.
The other thing I would say is stay true to sort of what you're focused on and what you, as an organization or as a CSO want to be focused on. You don't have to be focused on every single part of the program. So if you're just interested in the PMTCT program, or if you're just interested in the key populations program, focus heavily there, and start picking apart questions about why, asking questions, not so much utilizing the data, but about what's going wrong in the program. What is the design of the program that's being implemented, and what are they changing, particularly when they're not meeting targets? I think questions about what are you specifically going to change in the design of the program to improve its performance. Not just, oh, well, we think we'll improve better next quarter, but why do they think that? What are they changing? Who are the implementing partners? And what do those implementing partners say about what's going right and what's going wrong in the program?
Mm-hmm. Thank you so much.
Another thing that has worked for us is having a team with you that helps you look through the data. It's really difficult when you're just maybe two of you sitting in a meeting and having to look through as they go through everything really quickly. Having a team of civil society allies who you go with to the meeting, some who are looking at key population data, some who are looking at linkage data, is really helpful, because it means that it's not as tedious for one person to look at the entire thing. So it's really helpful. Another thing that has really worked for us is also just having our own set of recommendations from looking at previous data from previous quarters. So we already know key things that we want to come and look at even during the next presentation, because we know these are the things that we wanted to improve anyway in the program. So we have our own key things that when we go to a PEPFAR meeting with, we know we want to win, and that really helps in also just picking out the really important key pieces of data that we want to follow. Mm-hmm. But yes, that said, we are 4 minutes after our call should have ended, and I would like to really thank everybody who has taken time to join. I would really like to thank Brian for taking us through the slides that are really difficult for us to interpret. And just say that please feel free to reach out to myself, reach out to Kevin, reach out to Brian for any help you might need in interpreting your own country data. We are probably going to be doing it, so we would really be happy to help you go through if you are with your team. So thanks, everybody. Talk to you on the next webinar. Bye.
Thanks, everyone. And we'll be sending around a link to the webinar so you can.
Bye.
Thank you all.